Hey, everyone. Good afternoon, everyone. I'm excited to introduce today's distinguished speaker, Dr. Anthony Tomassoni, a nationally recognized leader in emergency medicine and medical toxicology here at Yale University. Dr. Tomassoni's career is a testament to the profound impact that expertise, collaboration, and education can have in shaping medical practice and public health response. Dr. Tomassoni's journey began with foundation in science education and human biochemistry, equipping him with a unique lens through which to approach medicine and toxicology. After earning his medical degree from the University of Medicine and Dentistry of New Jersey, he completed residency training in emergency medicine and a fellowship in medical toxicology at the University of Cincinnati, where he also served as an EMS medical director and flight physician. Throughout his career, Dr. Tomassoni has combined his passion for clinical toxicology with a commitment to injury prevention and disaster preparedness. His leadership as medical director of the Northern New England Poison Center and the Maine CDC Office of Public Health Emergency Preparedness brought critical innovations in public health infrastructure. Currently, he serves as the medical director of Yale's Office of Emergency Preparedness, where he continues to lead efforts in developing diagnostic and treatment guidelines for chemical and radiological emergencies. Dr. Tomassoni is a prolific educator and researcher with numerous contributions to toxicology and emergency medicine literature, including textbooks, wide-ranging publications, and invited lectures. He's received multiple teaching awards, including the American College of Emergency Physicians National Teaching Award. Whether in the classroom or the clinical setting, his dedication to advancing medical education and fostering collaboration has been inspiring. On a personal note, he is my go-to toxicologist. With the most recent ICU case in the last year, where I needed assistance with identification of a mushroom that one of our young patients intentionally ingested. Within about 24 hours, working with Dr. Tomassoni, we were able to send it out to a Connecticut state lab and have that drug, recreational mushrooms, correctly identified and preventing a patient from going from acute liver injury, ideally into acute liver failure. Please welcome me, please join me in welcoming Dr. Tomassoni for today's Grants Round.
It's too kind. I think you might be the first person that actually looked at my CV. So this afternoon, we do our EM rounds in the mornings. Odd for me to be doing this in the afternoon for you. This afternoon, I'm going to try to give you a little look at the world of toxicology through my eyes. As we set this talk up, there was interest in hearing about a few different critical care related poisons, any one of which could probably occupy us for an hour and a half or two. So I opted to do like a quick view from a height on some of these things for you. Part of the CV that you didn't hear about, I used to teach full-time, things like AP Physics and other goodies. Used to working with loud crews. If you have questions, I don't mind. If you stop me, it's a good time. So we can deal with whatever the issue is or the question is before we move on, start to lose people. If you want to redirect me at any point, I can switch styles, or this is your time. Let's make it work for you. Okay. Let's try that. The obligatory disclosure and your CME credit, the numbers for which are on the board if you're here in person. It's also going to come out in the chat for you if you're online. One of the reasons we're speaking today is that poisoning, maybe about 10, 15 years ago, crossed the line to become the top cause of unintentional death in the US. The opioid crisis didn't help that any, and is a contributing factor. From a toxicologist's perspective, understanding the fine points of the agents involved helps one to understand the situation and helps us to set a better course. Sometimes that course is to intervene with engineering controls, regulations to try and redirect poisoning. Good example might be about iron poisoning. Used to see a lot of iron poisoning back when I was a fellow in the first few years of my practice. I had my first iron poisoning in probably a couple of years, just 2-3 months ago. Why did it go away? Well, it went away because we realized that a lot of the iron poisonings were unintentional, involving toddlers who would see ferrosulfate tabs and go, oh, M&Ms. And there's no such thing as a really child-proof container, especially where something delicious might be involved. So kids would manage to pry the lids off these containers and they'd sit together and they'd go 10 for me, 10 for you, 20 for me, 10 for you. And we'd have a couple of kids that would come in with iron exposures. Problem went away when the poison centers and the Consumer Product Safety Commission went to the FDA and said, can we just have people blister pack these tablets individually? Genius, right? Wish I thought of that. But those are some things that we can do. So I want you to put your radar up when you have tox cases. If, like me, you don't know everything there is to know about a particular drug or poison, or you knew it once and you forgot it, look up what you need to know again. There are a lot of good references out there. Like Goldfrank's Toxicologic Emergencies. About the time I decided to be a toxicologist, it was maybe that thick. And now it's about that thick because our information has evolved, our writing has gotten better and more detailed. There's a book called Critical Care Toxicology. I've written for it. There are a couple of good databases. I kind of prefer Poisondex for the toxicology databases. Lexicomp's not bad. If you're looking for capsulized knowledge, you don't mind reading like outline format. There's one that Kent Olson does. It was also a very skinny once. It's a little fatter now, but it's paperback and relatively inexpensive. Poisoning and Drug Overdose. And you have a lot of friends. At the moment, there are 2 toxicologists taking call for you here. At one time, there were 4. There may be 4 again soon. If you're looking for us, go into one call, look under emergency medicine, under toxicology. We should probably get our own line too. I've noted that once in a while, they publish the wrong number for me. Use my 203 number. That should also be posted there. Sometimes the 475 number is incorrect, or it may not be on if I'm off campus. There are 3 safety nets that I like to have people use. They work for most of your clinical cases, but they especially work and they're tailored to toxicology cases. I like to teach folks to be sure they've got a whole database. I say this because for the first 12 years of my practice, I was the only boarded toxicologist in 3 states. So every day was a call day. And people would call me. And people would require frequent direction back to the patient to collect a little more history or a little more physical exam data. And that's okay, I don't mind. But as I tell my residents, you can't make a good decision with bad data. So try and gather, despite all the interruptions and despite the difficulties in eliciting histories from some of these challenging patients, try to collect the full data set. Once you have that data set, you kind of have a story. Look at the picture before you and just apply the common sense test. Say, hey, are these congruent or is something missing? If the situation doesn't seem to match the story, then you probably need more story. History is the key to tox cases. I like to say a tox case is a history case. It's almost always the way. Once in a while, we look into it with labs or other bits of data, but for the most part, you really need the history. Labs are a poor backup. And then I want you to think about toxicokinetics and toxicodynamics so we don't miss any opportunities to influence the course of a poisoning for the better. Little acronym, LADMER, stands for a lot of kinetic things: liberation, absorption, distribution, metabolism, and elimination, and dose response, which is a dynamic thing, what the drug does to our bodies. We had a good example of an interesting shift between pharmacokinetics and toxicokinetics this morning. I've gotten calls from the ED and step down about a patient who sucked down a 3-month supply of her Tomassoni and came in with methemoglobinemia. Fortunately, not symptomatic, but with a significant methemoglobin level. And she's refusing activated charcoal. We could have a whole hour's talk on gastric decontamination, but today, activated charcoal is kind of useful in that particular setting, not so much for the fact that she was kind of a late presenter, but for the fact that this drug has altered kinetics and overdose. It usually has an elimination half-life of maybe 20, 30 hours, but overdose, that can be as long as 77 hours. And part of that, a large part of that, is because the drug undergoes enterohepatic recirculation. And charcoal can interrupt that, actually appreciably improves the kinetics. So you take a week or two problem and turn it into a couple day problem if we're lucky. I think the team is trying to convince her to try some charcoal. So the picture that we see when we have a poison patient in front of us is the toxic syndrome or toxidrome. I want you to be very deliberate when you try to construct these toxidromes, when you try to identify these toxidromes, instead of like backing into it or lucking into it. If you take an intentional approach, make sure you look at your vital signs, think about what they mean. Think about the fifth vital sign, which for me is always mental status. If the central processing unit is not functioning correctly and the rest of this, well, my other vital signs exist to support the central processing unit, there's a problem. And then to that, I add other autonomic cues, clues, pupillary reflexes, presence or absence of bowel sounds, skin color, temperature, moisture, all those things. So at this point, when we have a picture, we can start thinking about potential agents that might be responsible, and we can think about how those agents might be working and what we can do to alter the course of this poisoning. But here's Latin for you. I think about liberation, might be someone, toddler, found a cigarette butt in the ashtray. They ingest cigarette butt. Or maybe they ingest whole cigarette. Which one is likely to be worse? Probably cigarette butt, because a lot of the nicotine that's been heated and pyrolyzed and condensed on the filter and in the remaining tobacco in that butt, it's bioavailable. And a lot of the nicotine that's still in a whole cigarette is not yet liberated. Then for pharmaceuticals, we have immediate release, sustained release, intermediate release preparations, as with Wellbutrin. And I think, is there some way that maybe after the sustained release verapamil overdose, I can make this situation less bad? And knowing that drug is going to be eluted from those tablets over many, many hours, I can pause and say, maybe I can wash these tablets out, which makes you think about whole bowel irrigation with something like polyethylene glycol electrolyte solution. If they never have a chance to liberate it, they can't absorb it. If they can't absorb it, I probably don't have to worry about at least that portion of the drug that we can eliminate. So that's an example of how we might alter liberation. And there's absorption. We mentioned activated charcoal in the case for enterohepatic recirculation and its interruption just a moment ago, so I won't say more. Distribution makes me think of the target organs to which this poison is going to travel and what it's going to do when it gets there. One of the ways that we can often alter distribution of lipid-soluble drugs is to provide another reservoir of lipid. So we might use lipid rescue as we would for local anesthetic intoxication. We'll talk about that in the context of some of our other items today. Metabolism can be our friend, it can be our enemy. If we metabolize something to inactive metabolites, that's just great. If there's a way to enhance that, that would be better. We don't have that opportunity too often. But sometimes metabolism can lead us to produce more toxic metabolites. Great examples would be toxic alcohols, methanol, ethylene glycol. And we can stop that metabolism with ethanol, or better still, with 4-methylpyrazole from Epizole. Acetaminophen is another example. We can add NAC to alter metabolism, produce less toxic metabolite, NAPQI, or we might even use fomepizole to prevent enzymatic catabolism of acetaminophen to NAPQI. So those are some examples. Elimination can often be enhanced for some inhaled agents. It might be by providing fresh air or oxygen. In the case of things that have a relatively small volume of distribution that are actually water soluble, we might use dialysis or CVVH. And then I use R to remind me that for all these drugs, there's a dose-response relationship, same for our poisons. It's important to remember that toxicokinetics and toxicodynamics may differ from pharmacokinetics and pharmacodynamics. I also use the R to remind me about enterohepatic recirculation. And after that, I think of two more things that I didn't list on your slide. I think about adverse drug reactions, and I think about drug interactions as well. So this is a little reminder about, let's do this, about concentration versus time curves, area under the curves related to the amount of drug we've ingested, and different thresholds. If we have too little drug, we might see any response at all. If we had a little more drug, we may have a desired response for that agent, and we may be within the therapeutic window. If we add more drug, we will cross over into the realm of toxicology, where we might have adverse responses. Between the threshold and the threshold for effect and the threshold for toxicity, we have the therapeutic window. I'll just call out toxin-induced seizures here. You guys are the experts in supportive care, critical care. This is a frequently encountered problem in toxicology, and toxin-induced seizures are a little different from other seizures. They're usually not focal. They usually occur because we have a population of sick neurons, altered chemistry, often acid-base electrolyte chemistry. And they're usually, but not always, GABA related. So agents that don't work along the GABA axis don't usually work well for toxin related seizures. We usually use benzos. We sometimes use large doses of benzos. If that's not working for us, then we think about things like propofol, barbiturates, in worst case scenarios, general anesthesia, occasionally neuromuscular paralysis too, but never without monitoring an EEG contemporaneously. And that leads us to a quick discussion of sedation in toxicology. Toxicologists love benzodiazepines. We love them because they solve so many different kinds of problems for us. And they have a broad therapeutic index. They're relatively safe. They tend not to do things like lower seizure threshold. They don't have serotonergic effects like fentanyl. So we will use massive doses of benzos sometimes. A good example might be serotonergic crisis. We had one case not all that long ago. I think we gave 24 or 26 milligrams of Ativan in a space of about 20 minutes and still had difficulty controlling the patient. We finally had to decide to intubate the patient. Someone promptly said, "Oh, what are we going to use to keep him down? Let's try fentanyl." And I had to remind folks that not a good option because that is a serotonergic agent. So you're familiar with other adjuncts like dexmedetomidine, which I actually wrote in that critical care book. Agitation and altered mental status can really affect the outcome of a poisoning. Sometimes the altered mental status, as in the case of salicylate poisoning, is an indicator that something's wrong. It might be neuroglycopenia, which may actually reverse the AMS in the case of salicylate poisoning. It may be that we've caused a shift in acid base, allowing more drug to switch compartments, perhaps in the case of a cyclic antidepressant that'll allow more drug into the CNS, not a good thing. Then there are agents that kind of have central, peripheral, central feedback loops. We think of that in terms of cocaine, amphetamines. When folks have too much cocaine, too much amphetamine on board, they can be super agitated. The more we allow that situation to persist, the more other things are likely to change and decompensate. So when I'm picking my benzos for these different problems, I usually try to pick one that has a duration of action that's going to last about as long as my problem, but never tolerate agitation. In some cases, it can really lead to precipitous decompensation and decline. Yes?
Can I just ask for
Sure.
the use of benzos? We tend to not use them for medical purposes.
I know.
Hi, I just wanted to ask about the role of benzos since it's something we tend to shy away from in our clinical ICU for medical patients.
Sure.
And so I'm just trying to think about for seizure or something with somebody who's got enough of an encephalopathy, but also has a chronic condition that makes it harder to discern sort of where they are. If we're using these heavier doses of benzos, how do we tailor it appropriately? Like what tools do you look for to think about when to wean off the benzos in these more complex medical and psychiatric conditions?
It's a great question, but it's a case by case question really, which is what makes it challenging. I titrate to effect. And it depends on exactly what the situation is, exactly what the agent is, exactly how the problem is presenting. So I will titrate to effect, and then I have to use my best estimation of toxicokinetics to try and figure out how long that problem is likely to last before I attempt to lighten up on sedation and see where my patient's at that moment in time. If I see signs of agitation, it's just like dive, 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 because it's not a patient I'm prepared to extubate if they can't participate in their care, right? Sometimes. Oh, would propofol be better? Sometimes, if I can tolerate the hypotension associated with propofol. So this is a little bit like, I don't know, I like to cook. This is a little bit like cooking. And I probably don't make any dish exactly the same twice because the ingredients may be a little different, or I might not have something that I usually like to use. It's just over time you develop a feel for these things. And we're glad to help. We're glad to help. All right, this is a quick reminder. I call it the wiring diagram for our nervous system. Most of our basic toxidromes live along this continuum. We're going to highlight and discuss some of these today. So if you think about the autonomic nervous system, we've got the parasympathetic, sympathetic divisions. The preganglionic neurons are easy for us. Acetylcholine is the neurotransmitter all the way across the board. In the case of parasympathetics, the toxidrome is often called the cholinergic toxidrome, but I like to be more specific. I like to call it the muscarinic toxidrome because those are the receptors on our gut and our eyes, etc., that will receive acetylcholine from the postganglionic neurons to produce the toxidrome that we refer to sometimes as dumbbells, diarrhea, urination, meiosis, bradycardia, bronchorrhea, and bronchospasm, the killer bees, and then emesis, lacrimation, salivation. There is a cholinergic muscarinic twig in the sympathetic nervous system. It's actually kind of cool. I think of us as thermodynamic engines, right? We operate between a delta T, which is, since we're biological, confined to a pretty narrow range for success. And if we overheat, we become very inefficient and very sick, and we will cease to exist. So this is the cooling system. There are evolutionary biologists that think that this little cholinergic twig of our fight or flight response might be the reason that we're the dominant species on the planet. Think about it. If somebody let a tiger in the room, I only need to be faster than one of you. That tiger is really good at sprints, but that tiger can't run real far, real long. And we can, because we can cool. So if you're part of a herd, you have a survival advantage. And so that's what some evolutionary biologists think. Then we have the hardwired limb of our sympathetic nervous system, which releases norepi for our alpha receptors, and another limb here, which releases epi. You're familiar with epi and how it gets around. I don't think we have a good reason to talk about the somatic nervous system today. When I think about the CNS, there are two levels. I can make it real simple, or I can think real complex. On the real simple level, most of our neurotransmitters are excitatory. There are a few that are inhibitory. If I have those toxin-induced seizures, I think about those. Moving into a view of our toxicologic problems. I think about where these cases are likely to lead me. I think about lead. Someone once taught me, I have a lot of friends that have been in the military. One of them is a fighter pilot. He taught me a little tidbit I'll share with you. He said that in World War II, they had fighter pilots learn to shoot skeet. I'm like, well, why is that? He said, so they can learn to lead their targets. If you shoot at your target, by the time your therapy gets there, the target's somewhere else. You have to anticipate where your problem is going to lead you and address your therapy to that point in time. So the person in this little diagram who's shooting this little clay pigeon is shooting in front of it so that his shot and the pigeon arrive at the same point in time together, assuming we've done the job well. Talk a little bit about antidepressants as our first case study, and we'll do a little time check for you too. Use of antidepressants has increased quite a lot. I don't need to tell you that. You've seen it. What has changed is the generations of the antidepressants that are available and the relative portions of those agents that we see in toxicology. Cyclic antidepressant use in particular has declined for the traditional reasons, depression mostly, but we find applications now in neuropathic pain and so on. So they're not gone, but they may be a little more dangerous in the sense that back when I was a fellow, I would on many nights admit 3 to 5 cyclic antidepressant overdose patients, a couple at my home institution and a couple elsewhere in the state if I was on call for the poison center. Now that almost never happens. So people are less familiar with these agents. Unfamiliarity is a reason that some cases go bad, right? I mean, if you haven't seen it before, it's difficult to imagine where you're going. It's hard to get that lead. And that's where a toxicologist can help you. We specialize in a lot of things that are rare occurrences and unfamiliar. So in my life as an emergency doc, I might see 2 or 3 salicylate poisonings. In my life as a toxicologist, I see a few a year. So I get a lot more practice. There are tri and tetracyclic antidepressants. I will say that the tetracyclics are cardiotoxic, but they also show more neurotoxicity. They tend to have a propensity to cause seizures, even more so than the tricyclics. I'm sure you're familiar with many of the tricyclics. So the presenting toxidromes for cyclic antidepressants make a great example of another important concept in toxicology. Just because you have one poison, it doesn't mean you have one problem or one mechanism of action. I've listed 4 toxidromes here, and I've neglected a couple others. Some of these agents are serotonergic. All these agents are used because they're generally norepi reuptake blockers, so they have some pathomimetic effects that factor into overdose as well. We'll start with the way we recognize a lot of these poisonings. We recognize many people that come in with cyclic antidepressant overdose by the fact that they're anticholinergic. So antimuscarinic specifically. They'll have some sinus tach. They may have supraventricular tachydysrhythmias. They can have AV nodal dysrhythmias. Torsade is relatively rare. And of itself, that particular toxidrome doesn't worry me much. People generally don't die from anticholinergic poisoning. So what's another problem? Well, the next problem might be that these agents are very potent sodium channel blockers. So they increase duration of cardiac action potentials and refractory periods and delay AV conduction. The right bundle is more susceptible to blockade by these agents than the left bundle. So that's one of the reasons that you might see a right bundle branch block. You'll see duration in an increase in duration of the QRS complex. And historically, folks used to focus on that QRS duration. They noted that if you have an upper limit normal QRS duration of 100 milliseconds, there's actually an association with increased seizure frequency. That doesn't help me a lot because that's still a pretty normal looking EKG. When we reach 160 milliseconds QRS duration, we see an increased association with malignant dysrhythmias, VTAC, VFib. And then with a little study, as people began to recognize the pathophysiology of the problem, we realized that it's a shift in axis. It's that rightward axis shift in the last 40 milliseconds of the QRS complex that's going to give us probably our best indication of the fact that someone's sodium channel blocked and maybe subject to the complications of that blockade. The fastest way to look for that is to look for an R wave in lead AVR. If you see an R wave of 3 millimeters or more in lead AVR, your patient is definitely sodium channel blocked and toxic. And this is what's happening. If we take a look at our cardiac action potential, remember we have this slow, should be slightly upsloping phase 4 spontaneous depolarization with potassium channels, emitting potassium, and then we reach our gated voltage, maybe negative 70 millivolts or so, and this triggers our fast sodium channels to open, which in turn triggers some of our calcium channels to open, and then we see repolarization. In the case of class 1A agents, 1 Williams classification, and cyclic antidepressants, this is the shift that we get. Our fast sodium channels aren't so fast. That prolongs our QRS. Our repolarization happens later. That prolongs our QT. All these class 1A agents as antiarrhythmics are absolutely contraindicated. They love this stuff on board exams in emergency medicine and toxicology. They have a lot of ways of asking you related questions. Same is true of class 1C agents because of the slowed phase 0 depolarization as well. So class 1Cs are also contraindicated. Phenytoin is too. Lidocaine might be, according to some folks, the agent of choice. Class 3 agents won't work either, also contraindicated. And this is what you see. Here's your R wave in AVR, and this is a bizarrely wide QRS with a prolonged QT. Past that, it's going to start looking somewhat sinusoidal. Past that, the patient's likely to arrest. All right. Good news is patients don't usually die from sodium channel blockade either. And that's because we know how to treat that. We want to overwhelm the functioning sodium channels with a rush of sodium ions. So what other toxidromes exist? Well, these patients can sometimes, depending on their dose and the agent, go from awake, alert, conversant to comatose within about 20 minutes, 30 minutes, requiring intubation. And that's because these agents are super potent histamine blockers. In fact, the little pearl from the allergists and the dermatologists sometimes for people with horrible atopy is to use a TCA when they've outstripped the utility of other histamine blockers. And histamine, as you probably recall, is the major neurotransmitter for the reticular activating system that keeps us awake, right? So no histamine effect. That doesn't kill people because we know how to support that too. So what does? Well, it's usually refractory shock, and that happens for a few reasons. One is direct myocardial depression by cyclic antidepressants, but the other is that these are relatively potent alpha blocking agents. That's why you see so much orthostatic hypotension with older folks when you try to initiate these agents for them. It's always a caveat. So refractory shock is the most common cause of death for these folks, and somewhat difficult to treat, which is why it becomes refractory. So let's talk a little bit about treatment. How do we mitigate some of these problems? We do gastric decontamination, not well supported, risky in a patient that may lose their airway. We generally like to have a patient who's completely awake and alert before we think about administering activated charcoal. If we have a patient whose airway needs to be taken for another reason, that may provide us with an opportunity to do gastric lavage or to instill activated charcoal or both. To address our hypotension, we want to make sure our patients have adequate preload. As poisoning progresses and SVR is lost, they may have a little more volume requirement. We can chase that. There's temptation to run right to something like norepi, which is a direct acting agent and likely more effective than something like dopamine, which is a mixed or indirect acting agent. But I think you're going to get more bang for your buck in most of these cases by giving sodium bicarb. We'll talk about how that works. It's very important to think about underlying metabolic issues. If there's hypoxemia or if there's acidosis, you really need to correct that aggressively to try and get your blood pressure back. Failing that, we can think about lipid rescue because these drugs are quite lipophilic and they do have a huge volume of distribution. They may not be as amenable to lipid rescue as something like the local anesthetics, but we have seen some effect in cases, and there are some data in the literature to support that. ECMO is something that you should think about relatively early in the course because it takes a while to set up. I'd like to do more with that here. Hopefully we'll have a little more toxicology present soon. Sodium bicarb is a mainstay of therapy with cyclic antidepressant overdoses for a variety of reasons. Somewhere in the literature many years ago, someone wrote this up as an ion trapping effect. It is not. To ion trap, you have to have a weak acid or a weak base. Cyclic antidepressants are neither. So what we do see, though, is that as pH drops for these agents are weak bases, not like in the amphetamine trappable sense, but they are somewhat basic. They will ionize more, and the ionized form sticks to the sodium channels better. So we would like to make them less sticky. The other thing is if we free up a few more sodium channels, it'd be nice to shove sodium through there. We usually do that with bolus therapy. And our boluses are usually 1 to 2 milliequivalents per kilo, and they can be repeated pretty frequently. We shoot for a target pH of 7.5 to 7.55. If we overshoot a little, we need to back off. And we'll usually run a bicarb drip, more for the bicarb effect than for the sodium. If I really have an arrhythmia or a seizure problem, I want boluses of sodium ions. If I'm maintaining my patient, I just want to make as many of those channels free as I can. And for that, we'll do a bicarb drip, 3 amps and a liter D5W, right? 150 milliequivalents, functionally making it isotonic. We address VTAC or wide complex tachycardias aggressively if we are not getting everything we need to and our pH is rising to 7.55. We can try a little bit of hypertonic saline, 3%. Same 1 to 2 milliequivalent per kilo bolus. Torsade is relatively rare. If that happens, we think about cardioversion, and we'll usually use magnesium as a chaser for its stabilizing effects. When we use a lot of bicarb, we will shift some K. You might need to correct that gently, but patients tolerate relatively low Ks, 2.8, 2.5 pretty well most of the time. And we know that that K is going to come back out when we stop shifting it with active bicarb. Benzos for seizures. If we fail boluses with benzos, then we can do midazolam drip or propofol drip. I like propofol for that for sure, assuming I have the blood pressure for it. Possible role for lipid rescue, as we mentioned. No role for physostigmine, which is at one time thought to be beneficial. What we found is that this increases vagal tone, which decreases cardiac output and makes our problems worse. It's actually been reported to cause arrest. Since these drugs have such a high volume of distribution, there's no role for hemodialysis or hemoperfusion, and there may be a role for methylene blue with this type of shock as well. I'm going to leave you plenty of time for questions. Should I tackle a little bit of salicylate poisoning? Are we good with that? You want more time for questions, or should we pick off another poison? Pick off a poison? Yeah, we'll do it quick. I'll try to be efficient. Salicylate ODs are also less common than in the past. When I was a resident, a lot of the, it tells you how old I am. There was a lot of folks that would come in that were on a gram or even 2 of salicylates a day for their arthritis. And we just don't see that anymore, thank goodness. But what happened is somebody would maybe bump their dose a little bit, or they'd have a little diarrhea and they get a little AKI and now they're hanging on to more salicylate, or somebody would start them on Lasix, not knowing that their rheumatologist had them on a lot of salicylate, and they get a little AKI, and grandma or grandpa would come in, oftentimes confused and sometimes short of breath. If we were lucky, it was because they had some direct respiratory stimulation of the medullary respiratory centers by the salicylate. We weren't so lucky is because they were developing ARDS and getting leaky lungs and pulmonary edema, which is associated with high mortality. So those are the scary cases. There are a couple pitfalls that I want to make you well aware of, and hopefully we're not guilty of any of these things. But I've had cases over the years. Lawyers call me for these cases when they go bad, and the stories are almost always the same. Failure to follow serial labs, not dialyzing as the levels are rising, and the patients are no longer able to compensate. Early to intubate without adequate hyperventilation, or maybe just a short period of apnea during that intubation, in which the patient becomes acidotic. They get a shift in salicylate, more crosses into the CNS, they arrest. And late to dialyze is another one. We're not going to do any of those things. So presenting toxidrome, early respiratory alkalosis, progressing to classic anti-metabolic acidosis, you know, all that differential. This is a neat poison mechanistically because salicylates are weak acids and their pKa is right about 3-ish, near physiologic pH. So we can influence the course of this poisoning by ion trapping. Think about it. HA is the uncharged species. This is the one that's going to cross membranes readily. And it's in equilibrium depending on the pH with more or less hydrogen ions and salicylate ions. So if we're in the stomach with a pH of 2 where there are tons of hydrogen ions, if there's any A- around, it's pretty likely to be protonated. So that's one of the reasons that salicylates are rapidly absorbed from the stomach. When it's protonated, it's HA. That stuff crosses membranes readily and it makes it into the blood. In the blood, we'll have some HA, but the pH is higher, so our equilibrium starts to shift a little bit to include more H plus and A minus. So we'll have some kind of balance between HAs and H pluses and A minuses, but there's still some HA. We don't like it because as long as there's HA around, that can cross over into the brain. The brain is very dependent upon glucose metabolism, no surprise to you. And salicylates are uncouplers and they also poison the Krebs cycle. So they interrupt our ability to produce glucose. CSF glucose and serum glucose do not correlate well. It takes time to get glucose across the blood-brain barrier. So patients can be relatively neuroglycopenic when salicylates get up into the brain. So we would like it that salicylates should not enter the brain at all if we can make that happen. So what we're going to try to do in these cases is alkalinize our blood to force more of that HA that's in the blood, the serum compartment, to become H plus and A minus, which will not allow salicylate to cross into the blood-brain barrier. And we do that by providing lots and lots of bicarb, which is going to pick up our hydrogen ions and through the miracle of carbonic anhydrase, leave us with H2O and CO2. This is kind of what it looks like before alkalinization. The stuff is relatively free to cross compartments from tissue to plasma to urine and to be reabsorbed from the urine as well. After alkalinization, we force our equilibrium such that we end up with plasma HA and urine HA, which is then excretable. To make that happen, we really have to have an elevated urine pH. So think about it. These patients come in, they're sick. They may have been sick for a while if it's a chronic overdose or a delayed presentation with an acute overdose. They're making acid urine. It's going to take a lot of bicarb to alkalinize their urine. And we still have that same serum pH limitation of about 7.55 as our upper limit. So it's challenging to get the urine pH up, but it's critical, it's pivotal. Because if we look at creatinine clearance versus urine pH, creatinine clearance of salicylate, it goes up when we hit a pH of about 7.5 to 8, which is our desired target urine pH. We're going to do that by providing good basic supportive care, GI decontamination. Charcoal and salicylates, interesting. Charcoal binds very well to salicylate or vice versa. For every gram of charcoal that you drop into someone's gut, they will bind approximately half a gram of salicylate under your average or better circumstances. After about 16, 17, 18 hours, that salicylate starts to come back off the charcoal. So some folks, in some cases, will advocate for serial dose activated charcoal to slow that process if the patient's still sick at that point. Alkalinization is with sodium bicarb, and same goal, pH 7.55 for the serum, but 7.5 to 8 for the urine. We drop Foleys, we check urine pH with dipsticks frequently to see how we're doing. We send frequent BVGs, ABGs as needed. We start by bolusing 1 to 2 milliequivalents per kilo, followed by a drip. Same recipe, 150 milliequivalents in a liter D5W. We usually run that drip at something like 100, 150. Big patient, 200 cc's an hour. These patients are always fluid down. They third space a lot of fluid. They have a lot of losses through respiration and other channels, increased urine production too. And no benefit to forced diuresis. They will have a high urine output. What's going to make the biggest difference for them is the urine pH. One of the things I hear a lot is the patient looks tired. And you'll look at them, diaphoretic, their hair will be wet and stringy, slumped in bed, and they still have prodigious minute ventilations, 20, 30 liters per minute. It's really important not to underestimate that. So whenever it's possible, I try to get some kind of handle on what their actual minute volume is so that I can, if I need to take their airway, match it or exceed it. You don't have to undermatch them by very much, and you'll run into trouble because as their PCO2 rises, they will have acid-base shifts in places where we're not going to measure it. We might have an alkalotic looking serum pH, but in the places where it really counts, if they're retaining a little bit too much CO2, things are decompensating. So they're quite insidious. And that's why we try to forestall intubation as long as we can. If we have to do it, we're going to bolus sodium bicarb. We'll sometimes try to use an agent that allows the patient not to be apneic during that period when we're actually intubating. So you might think about ketamine. If you're going to intubate and you're not going to use something like ketamine for a sort of kind of awake intubation, then you really want to make sure it's an airway that's going to go quickly, smoothly, and you will bolus probably 2 milliequivalents per kilo of bicarb right before the procedure to allow for that little brief period of acidosis that's going to occur with apnea. When we try to alkalinize that urine, it's important to remember that if the patient's hypokalemic, their body is going to resorb K from provisional urine, and it's going to throw hydrogen ions in there, and we're not going to be able to alkalinize that urine. So your goal potassium for these patients is about 5.5. It's better for them to have a little bit of excess. And we talked about airway. Ventilator settings are critical, but you guys are the pros at that. And finally, hemodialysis for patients that are significantly poisoned with elevated levels around 90 to 100 milligrams per deciliter. They're prime candidates for hemodialysis. CVVH will also work, but they usually use intermittent hemodialysis. If you don't have readily availability of salicylate levels during dialysis, it's usually 4 to 6 hours of dialysis. But I don't think that's a problem for us here. What else should I tell you about that? The X-Trip working group has done indications for dialysis for a lot of different poisons, salicylates among them. That group is comprised of critical care folks, emergency docs, toxicologists, and nephrologists, and they can provide you with great guidance. This is a poison, as many are, where we're not going to treat the poison, we're going to treat the patient. The presentation and the indications for dialysis are going to vary a little bit depending on things like the age of the patient, the chronicity or acuteness of the overdose. So to talk about a couple of patients that I've treated over the years, if you have a young patient, they may treat, they may tolerate a level of salicylate like 100 milligrams per deciliter or so. Not more than that. More than that, we're going to dialyze. If they have any degree of renal dysfunction, we might drop that to maybe 90 milligrams per deciliter. If you have an older patient, they may not do well. And depending on where you're at in the course of poisoning, you may end up dialyzing them with levels as low as 50 or 60 or 65 milligrams per deciliter. Folks over the age of about 60, 65 don't tolerate salicylates well. Even if they have an acute overdose, you may end up dialyzing. If it's a chronic overdose in a younger patient, you may still end up dialyzing them at around 65 milligrams per deciliter. So there's so many variables. We just, again, like in response to your question about the benzos, we have to tailor them to the individual patients. And that's why we're here as toxicologists. We love to get called about tough cases. That's what we live for. We love to get called about puzzles. I didn't realize how much I love solving puzzles. I should have seen the signs early in my career, but I didn't figure it out until I was a toxicologist for a couple of years. So I think I'll leave it there for you. I should put up, we'll do calcium channel blockers, beta blockers another day. So on the basis of what you just heard today, if I say poison, a lot of folks might say antidote, especially if they like to read murder mysteries and all. Toxicologist is more likely to throw in with you guys and say supportive care, right? We just talked about a couple of notorious poisons. There really are no specific antidotes here for the poisons we talked about. It's all about supportive care. And if there's an antidote, you should probably know it exists and use it, but most of the time, this is what it is. So I had a friend, program director, used to tell us this all the time. If there's any chance you're going down, take a consultant with you. Toxicology is here for that. Thanks for your time and attention.
Thank you so much. A little time for questions. Does anyone have a question?
Thanks so much, Luke Davis. Great talk. Two questions. One is probably pretty straightforward. Maybe you could just say a little bit about when we should consult the toxicology service or contact you versus poison control. I know that comes up sometimes.
Yeah, early is always better. I leave my phone on. It's on 24/7 unless I'm on a plane. I don't do as much stuff for the government as I used to. There were times and places I couldn't leave my phone on. It's almost always on. Call me. I don't care. Whether I'm on call or not, it's okay. Call me.
Okay, thank you.
If it's not me, it'll probably be Asim Tarabar. We're probably in one call. If for some reason you can't get one of us, do what the Poison Center does. They know my phone's always on. They call me if there's a problem and they can't get their regular consultant. You can call them. I would also encourage you to call the Poison Center with these cases for a couple of reasons too. One is I'm going to need to track our cases. I'm kind of hoping that we may be able to start a toxicology fellowship here. And I'll need to be able to prove my point that we have enough volume here. So when you call those cases in, that's good for a lot of reasons. It's good for them. It's good for us. The other real important reason that I like to have, especially ED and critical care, call the Poison Center is because they will track cases over time. And there are days when you're on the floor and you're busy and you don't want the call from the poison center, and I get that. However, there are days, and some places more than others, not so much here, but some other hospitals where the resources aren't as robust, and they'll call that patient that got transferred out of the ICU to the floor. They'll call about that patient, and the patient's not doing so well. And they'll say, hey, Tony, you know that patient we talked to you about yesterday that got admitted to, the patient's not doing so well. Would you mind giving them a call? And gives us a chance to try and correct problems before they escalate or the hole gets too deep. So love to have you call the poison center. Like to have the patients dual tracked. Call us if there's an acute problem. There are times when we're around and actually physically present. We can come see your patient. A lot of this stuff, especially since I got a lot of practice doing it as a poison center director, we can handle over the phone. Kind of goes back to the early slides I showed you. I need to see that patient through your eyes. So the better picture you can paint for us, the more I can see that patient, the better I can help you over the phone. If that's not working, I'll come in.
And then the other question, a clinical question, just in the context of opiate use disorder and a lot of contaminants in the drug supply, xylazine,
Oh,
and
yeah.
many other things. Could you just give some thoughts and pearls about what we should be thinking about besides the traditional approach to just opiate toxidrome?
Yeah, you're not the only person who's called me with that question. DEA called me about 2.5 weeks ago and they said, hey, have you been seeing more patients that are difficult to reverse? So, well, yeah, we have our share of patients that are doing fentanyl with xylazine. And I turned it around on them because they have a beautiful lab in New York. They analyze specimens, and we have friends out west that do suspect analysis for us when we have weird cases. And they'll look for like up to 7,000 analytes, some of our friends, so that we can see what's happening with the drug supply. But what generally is going around now in our immediate area is fentanyl, and DEA told me recently that it's almost all contaminated with xylazine. We had a person who went down in the lobby of the emergency department after a little trip to the bathroom. They found 2 syringes. They gave 6 milligrams of intranasal Narcan. Came back to me. He was breathing once, maybe every 20 or 30 seconds. I gave another 2 milligrams intranasal while we got a line. I think we gave 4 milligrams of IV naloxone, and he never really woke up, but his respiratory drive resumed. And I presume that was the fact that we had pretty much blocked all the fentanyl, but we're stuck with xylazine left over. Didn't require intubation. Some will. There are other drugs that are on the horizon and around the states, and it's only a matter of time before we see more of them here. There are the nitazines like isotonitazine and its cousins. There is purple heroin, brorphine with a BR, that's out in parts of the country. My sources at DEA and other government channels tell me that the cartels over our southern border have at least a 10-year supply of precursors to make some of those, so that if their supplies were cut off cold, we'd still have drug problems for a good 10 years. Yeah, so it's a great question. But yeah, there are all kinds of goodies out there. We had a good run-in New Haven with synthetic cannabinoids. There are over 700 synthetic cannabinoids, none of which are any good for really getting high, many of which have horrible side effects. Some of them cause asystole, bradycardia and asystole. They're often admixed with other agents to mitigate some of the horrible side effects and improve the high. So very often those are complex cocktails. And we'll see the same with opioids, I'm sure.
Thank you.
My pleasure.
All right. Well, it's 3 o'clock. Thank you so much for your time
Thanks for
and
having me.
presentation.